leads to arterial insufficiency. These wounds are very painful. So if they're very painful, what was the number 2 benefit I just told you? I'm sorry, I couldn't hear you. Yes. So you are giving your patient an excellent benefit for reducing pain, and here's why our products do that very well. Is because we form an occlusive dressing property. When you have an occlusive dressing property and you're capping the free nerve endings, the patient's pain threshold either mitigates, ameliorates, or disappears. And if they're concerned about aesthetics, they don't have any scarring. That's pretty impressive. Okay, so, again, I want you to think, please, arterial insufficiency, venous stasis, painful, yes. They happen to initiate because of different pathology, but the same excellent solution. Every one of these etiologies, regardless of how they start, we have the one-stop solution for you. That's pretty good. Where in medicine do you know that you have all these problems, I give you one solution? Really nowhere, except for here. Okay? All right, skin tears. We see this is very common in the elderly, patients who have decreased nutrition, patients who have decreased turgor and mobility. You know, when we go to see a patient on the ward, we always check for hydration and nutrition. We check the turgor and mobility, correct? Okay. We see it's decreased in patients who are elderly because they don't really like to eat. They have poor nutritional status. They're nutritionally compromised. So their skin's very frail. And when you go to help them out of the chair, accidentally, they start to tear. So you have a partial and a full thickness. And here's one with a flap. If you use our amorphous gel product here on the underside and put the flap over, you preserve the integrity of that flap and heal that skin tear. Anyone want to take a guess how long our skin tears heal? Wow. You used our products before, right? It's 7 days. One application, 7 days, you have a healed skin tear. That is pretty impressive. That's excellent clinical outcome. That's what we want. As physicians and nurses, as clinicians, we want excellent clinical outcome. That's what we will see here. So skin tears, problem. Now, this is a problem for us in the clinics, on the wards. This is a problem. Let's spend a little time here. Okay, we see here that pressure ulcers happen in 4 stages. Stage 1, erythema. Stage 2, partial. Stage 3, full thickness. Stage 4, exposed bone and tendon. Okay? You don't use our products on stage 1. Because stage 1 is no break in the tissue. Erythema is just redness. You have to have a break in the tissue in order for the product to work. So we don't, even though it's FDA approved for stage 1, clinically not relevant. When you have a break in the tissue, you put the product in there. Now we have very good results with granulating over exposed bone and tendon in a stage 4. Patients, in fact, we saw a patient at Hospital Kuala Lumpur the other day who had a stage 4 coccygeal wound, exposed bone, and we're starting to granulate. Anyone tell me why you think we're granulating? What's that word that begins with an A? Angiogenesis. This guy, madam, is great. Excellent. You're understanding the principles, understanding the mechanics of wound healing. So therefore, if you have the angiogenesis, you're able to proliferate that tissue to get the fibroblasts to do their job. We are granulating over this type of decubitus. And here is a cross-section of what that looks like. So regardless of the wound condition, you have the solutions in your inventory in this hospital to be able to get these wounds healed. We have one product in particular, which we're going to do a demonstration in a few moments, called Gold Dust. It is composed of a hydrophilic polymer that loves to attract fluid. And in a very exudating wound, which we don't want exudation because exudation leads to the production of bacteria, we don't want that, that the product will absorb 100 times its weight. That's a lot. We're going to have to do that demonstration. You're going to be very impressed with that. Once we're able to absorb all that exudate, now we use our gel, the amorphous gel, and we're able to granulate. Excellent. Gold dust first for the exudation, and then we have the amorphous gel for the granulation. And as well, the gold dust reduces the odor and is very, very well known to be bacteriostatic. So we have these products to match these wound problems. Now, we know that sometimes in wound management, we have tissue that becomes undermined. And we have tunneling. I'm going to show you this right now. Here's what I do. If I have a patient that has undermining, or has a tunnel, or has a sinus, I take a syringe, I use our amorphous gel, and I pour this right into the barrel. I put the plunger back, I remove the airspace, and here is an excellent applicator for getting the product into the deepest crevices of a wound. Because what you need to do is you need to